Okay. So self-expression men. We're going to talk about, again, I always like to do a little bit review of what's normal. And what we're going to be talking about a lot today is 1, the prostate, and 2, the testicles. So the prostate, it basically it creates some extra fluid that you have your seminal vesicles right here, and that's what carries your semen. And when it passes through the prostate. I don't know if you can see right there in that picture. It kind of passes through the prostate to go to the urethra to be ejaculated. So this carries the semen. Your prostate kind of secretes some fluids, and that's what's getting ejaculated, is all of that. So, I mean, you don't need to write that. I mean, it's basically just telling you, produces secretions. It's about walnut size. And then the good thing, it's not essential to life. And also important, it's only in males, okay? So women, you cannot have prostate problems. This is just the men. Okay. So when we're talking about like history and physical exam with men, one, we want to make sure that we do, when we're getting a good history, we do least sensitive to most sensitive. So the first thing out of the bat, we're not going to start and say, well, how often are you having sex? Do you have sex with males or females? Do you have any STDs? No, you're going to start, with just more broader questions because it can be a sensitive subject. People get embarrassed, and then go to the more sensitive topics like sex and STDs. You want to know about past medical history. Things that are important are like mumps, because if they have orchitis, it can lead them to be sterile. Diabetes can affect the male system. The endocrine system that we just talked about can affect. And in physical exam, you want to look at things like, with adolescents, we're going to talk about testicular cancer, which unfortunately is very common in adolescents. You want to look at Tanner staging, like hair distribution. Also look at the penis size. You're going to look at the meatus, which is the tip of the penis where the urethra comes out. You want to make sure that it's center, that it's not off to the side. Because when we talk about kids, sometimes especially, those parents will come in and be like, my son can never hit the toilet. And oftentimes it's because the meatus is not center, it's off to the side. So they really, unless they're like turning and twisting, they really can't hit the toilet. So you do need to make sure you do a good exam on all of that. Need to look at the scrotum, that there's 2 testicles within the scrotum, that normally the left side hangs lower than the right side. They don't normally hang exactly even. And we're going to talk about doing a testicular self-exam in just a second. So that's just kind of the general. So the first one we're going to talk about is benign prostatic hypertrophy, BPH. So what is it? It's an overgrowth of the prostate cells. So remember that picture that we just showed you, right? Here, right? The prostate's sitting right here, okay? So this prostate, which you've got your bladder there, you've got the rectum there, and you've got basically, the urethra coming through that prostate, right? So that's going to help you remember what kind of symptoms. So if my urethra, which carries my urine, is going through the prostate, and my prostate gets bigger, it's going to put compression on that urethra. So I'm going to have all sorts of urinary symptoms, okay? And the difference between BPH and prostate cancer is where the growth comes from. In BPH, the growth is coming from cells inside the prostate, whereas when we talk about cancer, it's on the outside. So because you have BPH, it does not increase your chance of having cancer. They're not related at all. A lot of people think, oh, I've got BPH, I'm going to get a higher chance of cancer. Nope, they're not related, even though they're similar. So overgrowth of the prostate cells inside the prostate. So risk factors are family history, especially a first-degree relative. Age, 50% of men over the age of 50 will have BPH, and 90% of men greater than 80 will have BPH. So most men will end up having these symptoms. You're welcome, men in the room. There can be environmental factors, like decreased physical activity is related to it. Diets that are high in zinc, butter or margarine, or alcohol are at increased risk. And actually diets that are high in fruit are at decreased risk. Obesity leads to it. And any change in the endocrine system. So when getting a history, like we talked about, we want to know if they have any endocrine disorders. All right. So again, the clinical manifestations are all urinary related. So they're gradual, because it's not like the prostate just all of a sudden, boom, gets big. It just gradually gets bigger and bigger and bigger and causes that compression. So they're going to have a weak stream. That's one of their first complaints, is they feel they have to go. They have a urgency to go. They have to go more often, but when they do go, it's not like a whole lot of urine comes out. It's a very weak stream. And they get this post-void dribble because their bladder is so full and they're trying to push out urine past this obstruction. There's urine that gets left in the bladder, so they kind of dribble just all day because they can't really release it all in a normal. They don't have as much control over it, if that makes sense. They have nocturia, so they urinate at night because, again, they lose control because the bladder just remains over-distended or overfilled because they can't empty the bladder normally because they can't get past the obstruction. And same incontinence is the same idea. But most men will tell you they feel they have to go and then weak stream. I think there's lots of movies too that reference it and make jokes out of it. I can't think of one off my head. So how do we diagnose it? History is the big thing. They come in and complain. They say, I have to go so bad, and then when I go, I have a weak stream, or I'm waking up and I'm incontinent at night. So if that's the case, we're going to do a digital rectal exam. And we're going to be looking for the enlarged prostate. And pretty much we recommend it in all men over the age of 40 to get a digital rectal exam. So men in here over the age of 40. Yay! So when I tell you a story, because I know you guys are all dead, and before you go to psych, you'll get this lovely image. So when you go to nurse practitioner school, you guys do like physical exams, right? Like heart sounds and lung sounds. Well, we have to do more in-depth exams, like I have to learn how to do a pap smear, and I have to do a digital rectal exam. And they use live models for us. And the way we did it is, okay, and I was all of like 21 and innocent. And here I am, and you have to sign up, and you go into this room, and I was mortified. And I had done you sign up for a female time and a male time. And you sign up your time, and there's like 4 of you in a room, and you sit, and there's your model, and they just sit. So I did my female first, and the model sat there and just opened up for all to see, why another woman then instructed us what to do. And we had to, do the whole exam and palpate the ovaries and do everything, while the model just sat there. They must be paid very well, that's all I have to say. Because all 4 of us did it to her, like we violated her 4 times in a row. And then the instructor told us what we did right or wrong or whatever. So then I'm signed up for my male time, and we go to do, and there's 4 of us like there, and I'm all like, oh God, don't look at me. And again, I'm thinking that the model's going to come in and then the instructor is going to come in and we're going to do it. So this, because the instructor always came in first and kind of explained what to expect, what we're going to do, blah, blah, blah. So, and then the model would come in and be, covered from the head up or whatever. And what. So he finishes talking about, making sure we have our gloves on right and all the things that we talk about, like your skills check-off, basically a skills check-off. And then it was like, okay, now we're going to go ahead and go. And he turns around and drops his drawer and bends over. And I was like, oh. So I'm sitting there as red as can be. And I was like, no, thank you, I'm good. I was like, I'm not going to participate today. And he was like, well, in order for you to get a passing grade, you have to participate and get checked off. Just like you have to get checked off on, making a bed. I mean, my ears are probably so red right now because So I go to do the exam and gloved up, and I'm up this man's rectum, palpating the prostate as he's telling me a little to the left, now a little to the right. Do you feel the ridges? No, you have to go a little further in. And I literally sat here like this, closing my eyes and doing it, wishing for that moment to be over. And then it was all done. And then the other 3 people went and did the same thing. And so I have felt a prostate once in my whole life, and that was during my skills check-off to be a nurse practitioner. So for all of you wishing to go on, I wish you all the best. And I hope you'll come back and tell me about that moment when you get to do that. So that is a digital rectal exam. And you get to feel that nice enlarged prostate. But I can tell you that it's normally like walnut sized. It's pretty small, but when it's enlarged, it almost feels like a heart. And you can kind of feel a little ridge in it. But it's nice and smooth and firm. That's going to be different because when we talk about cancer and we talk about outside, it's going to be more nodule. We get a UA in culture. This is really important because, again, what's running through that prostate? The urethra, right? The urine. So if we're having a backup, and we talked about this a little bit, right? You have the, I never have these to write with. Oh. You have the kidneys here, and you have your ureters and your urethra, right? So if your prostate's sitting here and it's compressing everything down, urine is going to go back into the kidneys, back into the bladder, and then eventually go back into the kidneys. And that's where you get that reflux. So the biggest complication from BPH is that we have damage to the kidneys, hydronephrosis, because of the backup. So we often get a UA in culture, and we're going to get labs like a BUN and creatinine. If for any reason your BUN and creatinine are elevated, they need a catheter, okay? Because that means that my kidneys are starting to get involved, and that's one of our biggest worries is that they're going to be involved. So when we look for, also, whenever you have a backup, and urine sits in the bladder, it increased risk of bacteria, so infection. So the UA in culture is going to help determine if there's any infection. Yep, like I said, if BUN is high, then we know that we have refluxed enough that we now have kidney involvement, and that's a problem. We're going to get a PSA, which is prostate-specific antigen. But unfortunately, it's really not that specific because it can be elevated for a bunch of different other reasons. Aging, it can be slightly elevated. If they've recently ejaculated, it can be elevated. If they've had prostatitis, it can be elevated. And I find this one funny. If they've been on a long bike ride, they can also be elevated. So there are other reasons why your PSA can be elevated. So you can't just say, oh, it's not elevated or it is elevated to help distinguish between the two. But we do get it to help. But if for some reason you do have positive DRE, meaning an enlarged prostate by digital rectal exam, and a positive PSA, then you're going to get a TRUS, a TRUS, a transrectal ultrasound. that actually gives us a view of the prostate, and it helps us kind of differentiate from prostate cancer if the PSA is high. So again, one of our main focus is to relieve the symptoms and to prevent any complications. The biggest one being hydronephrosis. Because basically the only problem is that this just causes constriction. You know, it's not cancerous, it doesn't really affect anything else except for urine flow. So we just want to, you know, prevent any complications from stopping urine flow. They might have to make some dietary changes or lifestyle changes. Obviously, since obesity is a risk factor, if they're obese or not active, we want them to get more active, lose some weight. Some diet changes. We don't want them to have any caffeine. Caffeine can cause bladder spasms, and we don't want them to spasm. We don't want them to have large amounts of liquid at one time, because imagine if you all of a sudden drank like a gallon of water. Now you have that gallon of water sitting on the bladder. That's going to cause a lot of pressure working against that constriction. So we recommend smaller, more frequent liquids. You don't want anything like anticholinergics or antihistamines, because that can cause urinary retention. So we don't want anything that's going to retain the urine anymore. We already have a problem with that, so we don't want to give them anything that's going to make it worse. Kegel exercises, we want to strengthen their pelvic floor muscle. And medication. So these are all non-surgical. For BPH, if it's not really bad and we can control it non-surgically, that's the goal. So we can give the 5-alpha reductase inhibitor. And all that basically does is, and you guys have probably heard the Proscar, but it just reduces the size. Unfortunately, it does take about 3 to 6 months to work, though. So it's not that something we give and it's going to start working in a few days or a week. We start them on this medication, and in about 3 months, they'll start seeing a relief in symptoms. So they start this med, this huge prostate gets smaller, and now I don't have frequency, I don't have urgency, I don't have retention. We can also use alpha adrenergic receptor blockers. So a lot of times what we'll do is start them on these first, because they just relax the smooth muscle. They don't do anything about the size of the prostate. They just relax everything, so it makes the urinary flow a little bit easier. And oftentimes they'll start them on both things, this one first because it works right away, and then you're going to add this also, but knowing that this is going to take some time to reduce that prostate. Sometimes they'll use an herb, I think it's saw palmetto, that can increase urinary flow too. If for some reason they're having signs and symptoms of hydronephrosis or severe kidney involvement, we don't have time to kind of wait with our non-surgical options. We're going to have to do surgery. Now, there's a couple different types of surgery. You'll hear it. There's a laser surgery, tuna. I think the other one is TUMT. But the one that you guys are going to see most, that's used most frequently, is the TURP procedure. And it does stand for something, and I don't know what it stands for. I don't know. I'm sorry. There you go. Transurethral resection of the prostate. So. No external incision. I'm sorry. So what they do is they go up the urethra into the prostate and kind of rotor-rooter it open. As pleasant as that sounds. So there's no external incision. It's just, they're just going right up. All right. So with that, the big thing, has any of you guys seen continuous bladder irrigation? It's pretty cool. Not for the patient. So because they've gone in here and kind of rotor-rootered this open and, really irritated that urethra, the blood clots are formed very easily, especially that 24 to 36 hours. So what they'll do is they'll leave the catheter in there, and they get these huge 500 cc bags of normal saline. You can only use isotonic because we don't, remember when we talked about hyper and hypo, they had those fluid shifts. We don't want those fluid shifts to happen. So we get these 500 cc bags of normal saline, isotonic fluid, and we sit there and we basically use gravity and force this fluid up the urethra into the bladder to irrigate, and then it comes back out. Your output should always be greater than your input. So if you put in 500 cc's of fluid and you only get 400 out, then something's not going right? So you've retained fluid. So you have to make sure that you're getting out more than you're putting in. And the whole purpose of this is it's basically just flushing the system for the first 24 to 36 hours so that if there are any blood clots, they don't end up obstructing the urinary catheter or the urinary urethra. So they go ahead and irrigate the bladder for at least the first 24 hours to prevent any obstruction from the blood clots. And then they use it says opiate suppositories. It's supposed to be opium. O-I-P-I-U-M. Opium. So they use belladonna and opium suppositories, and that helps with the bladder spasms. Because imagine this is very painful for them. Super painful. We don't want them to strain to have a bowel movement. So they need to be on a high fiber diet. They need to be on some kind of stool softener or laxative. And we want to monitor for hemorrhage. There's a very high risk of hemorrhage with this procedure. Nothing goes rectally except for the medicine. The opium suppository can go rectal, but we don't do any temperatures or enemas. Oh, I'm going back. No one freak. Mm-hmm. So CBI is the continuous bladder irrigation. It prevents obstruction. So the belladonna and opium suppository, they also can use ditropan for bladder spasms. Because again, remember, they go in there, they kind of rotor-rooter. There's no external cut. They're doing it all through the urethra. And they kind of open it up so there's not that obstruction anymore. And again, this is not the first thing they do. They're going to do this once my non-surgical stuff hasn't worked. They're going to leave it there and they're going to irrigate that bladder with those large amounts of saline so that the blood clots get flushed out. After about 24 to 36 hours, they take the catheter out and they allow the patient to void. The patient has to void within about 6 hours. If they don't have any urine output within 6 hours, the catheter goes back in and they irrigate again. Now, it's very normal to see pink tinged urine for a long time with, afterwards. That's okay. But it should eventually clear up. If it doesn't clear up or it turns red, then you're looking at a risk for a hemorrhage. Plus, you're going to look for other things. What vital signs? What? Blood pressure would be low, pulse would be high. Their labs might be affected if you're getting lab work done. So we monitor them very closely because they are very high risk for hemorrhage. If you take it out and within 6 hours they void, then you're okay. You don't have to reinsert the catheter. But if they don't void within that first 6 hours, you do have to reinsert for a couple more days typically.
Are those catheters inserted by nurse or by doctor?
Most likely they're inserted by the doctor. Yeah. This is not your normal urinary catheter.
Yeah.
It's something, yeah.
Too lumen.
Yeah. This is not like a Foley cath. Mm-mm. All right. So any questions about BPH? That's our most involved one. All right. So prostate cancer is a malignant tumor of the prostate. And as you can see, it's on the outside. So you see like a normal one is nice and smooth and firm. And with BPH, it would just be bigger. With cancer, it's no longer like smooth and firm. You're going to feel some nodules because the growth isn't happening from the inside out. It's happening on the outside. So it's a tumor of the prostate on the outer aspect. It's the second most common cancer. It's slow growing also, and it's often hormone dependent. That's why we need to know things about endocrine system and diabetes, because it can affect. Risk factors, men greater than 65 are at higher risk. African Americans are. And again, just because you have BPH, it doesn't put you at higher risk. So the clinical manifestations, again, it's still affecting the prostate, right? So I still have the urethra going through the prostate. So I'm still going to have those same clinical manifestations. So I'm going to see that weak stream, the frequency, the dribble. If they start complaining of things like pain in the lower back, you worry that it's metastasized because then it's in the bones. You hope that when they come and complain that it's just urinary type symptoms. Again, we're going to diagnose it by the history. The digital rectal exam. It's enlarged, and again, remember it's going to be nodular. It's often asymmetrical, so when you do BPH, and I said it's almost like a little heart, and you could feel it, it was nice and smooth and even on both sides. With prostate cancer, because it's cells growing at the outside, at different rates, they're going to be either uneven or you'll feel that bump over it. Again, the PSA could be elevated, but it's not definitive. There's all those reasons, like, I don't know, you just went on a long bike ride, which is the weirdest thing for me. A normal PSA, by the way, is like 0 to 4, so anything higher than that is abnormal. If you're worried, if you're worried about, again, the digital rectal exam is positive and your PSA is positive, you'll do the transrectal ultrasound to look at it. But the best way to diagnose it is by a biopsy. And if the biopsy is positive, they need to get bone scans, MRI, CT, because it can metastasize. Now, prostate cancer is a little controversial because a lot of people live with prostate cancer and a lot of people die with prostate cancer, but don't die from prostate cancer, if that makes sense. So a lot of times, if it's early, they may not treat, they may watch. It's not like I'm trying to think of like a super aggressive cancer. Like your pancreas tends to be super aggressive. But this is not a super aggressive cancer. So what they'll do, if it's caught early and they remove it, then it's 100% curable. But a lot of times they'll just do radiation, chemo, hormone therapy, and kind of slow the cancer down and prevent the symptoms, because they want to look at like that, quality of life versus quantity. Because are we really going to do surgery on an 80-year-old man for prostate cancer that could probably live with this for 10 years and be okay? Because the surgery is pretty involved. It's called a radical prostatectomy. And when they remove it, they remove the entire prostate. Sometimes they remove part of the bladder. They remove the seminal vesicles that we talked about that come in there. So it's very kind of big, and they're really high risk for infection. So it's a retroperitoneal incision. So with this one, unlike your BPH where we just kind of go in and rotor-rooter, this one they actually make an incision in the perineal area. And you can imagine stooling makes that almost impossible to heal. So they're at really, really high risk for infection. So if your patient does end up getting a radical prostatectomy, then that's going to be one of the big things you monitor for. You're going to have to keep the skin very clean. You're going to have to find alternate ways for them to have bowel movements, or, making sure that they won't be able to wipe. They may have to use water to rinse off. You're going to have to look at drainage from the incision site, any redness, check for fever frequently. Because if they get sick, they're going to get sick and they're going to get fast. And they're most likely going to be older, so they're not going to have the same reserves. We give a lot of supportive care. If they've had especially if they've had surgery, we the Kegel exercises. And everyone know what a Kegel? I know my females probably all know, but do my males know what a Kegel exercise is? Okay. Or those who have wives? Do you know what I'm talking about? No? Okay. Squeeze your pelvic floor. Squeeze it. You feel it? That's a Kegel exercise. You just squeeze. It's like any other muscle that you build, lifting, biceps or whatever. You just squeeze that pelvic floor, and that increases the muscle. It's really important, especially if they do happen to have a radical prostatectomy, then you need to make sure they're doing their Kegel exercises, because otherwise they're going to have incontinence. And that's most women who've had a baby or have any problems know that's why we do Kegel exercises, so that we don't have incontinence. Good catheter care, pain meds, because obviously they're going to be hurting. It says pain meds. And that's it. Anybody need me to stay on there? We good? All right. So last but not least, testicular cancer. It's like that. I don't find that to be the most appropriate picture, but I didn't make these slides. I guess so. All right. So testicular cancer is actually pretty rare. I mean, most people have heard of it because of like Lance Armstrong, right? But it's actually pretty rare, and it's very common in young males, 15 to 34 years of age. So that's why it's really important for them to learn how to do a testicular self-exam. It's a tumor of the testes, and they tend to metastasize very quickly. So early recognition is super important, because it's treatable if we recognize it and treat it early. If it goes too long, it metastasizes, and then it's harder to treat. And I don't know why, but typically the right testy is more involved than the left. That's just a tidbit. So I can never say this one. It's undescended testicle. If they have a history of an undescended testicle, they're at higher risk. If they had a history of mumps that led to the orchitis, then they are at higher risk. If they have a family history of testicular cancer, they're at higher risk. Other things like if the mom had a history of HIV, if the patient had a history of HIV, or if the mom was exposed to DES and why the baby was in utero, then they have a tinier, higher risk. And also if they had inguinal hernias, they tend to be a little higher risk. But those are the big ones. The undescended testicle and the mumps, those are big, big risk factors. So when they present, it is a non-tender, firm lump or swelling in the testicle. They don't hurt at all for them. There's no pain. They can have a feeling of heaviness. And if they present with things like back pain or cough along with these symptoms, then there's a high suspicion that they've metastasized to the lungs or to the bones. And that's a big concern. Because like I said, this is curable if caught early, but they metastasize very quickly. And once it metastasizes, it's way harder to treat. So, again, history and physical are super important. This is why we do testicular exams at every well check, and why it's so important that males, teenage males, get taught how to do a self-exam. Because who's going to be the one to come to you and tell you, I feel a mass on my testicle? It's, they're going to be the first ones to check. When you do your physical exam, when you transilluminate, so you can take your pin light and put it on the scrotum, and you all are going to go home and practice now. Huh? I know, everyone's like, ooh, I can't wait to go home and practice it on my significant other or child or whatever. Don't tell me about all the creepiness you do. No. So, but if you take your pin light and put it up to the scrotum, it should be, translucent. You should see the light come through. But when you have a testicular cancer nodule, it won't. So it won't transilluminate. The AFP is alpha fetoprotein and HCG. So those both are elevated. They're tumor markers. So normally those won't be elevated in males, right? A male shouldn't have a positive HCG, but they will be with testicular cancer. We don't do biopsies because very similar to a Wilms tumor, if you biopsy it, you could open it up and it could get out and metastasize. So we don't biopsy it. Typically, we just by history and physical exam, by their labs. And if we're worried about metastases, then we do a chest x-ray and CAT scan to look at the bones. All right. So an orchiectomy is the treatment once it's found, and that's just a removal of the testicle. So you remove the tumor, and you can't just take the tumor off the testicle because, like I said, if you try to take the tumor off the testicle, you could rupture it and it could spread. So they just remove the whole testicle that's involved. They get radiation and chemotherapy. It works very well on just that area. And if we diagnose it early and treat it early, the surgery is relatively quick and very little complications afterwards. And they do really well long term. a physician assistant I worked with at All Children's had it, and it was amazing to me how well he, recovered. But we need to diagnose it early by teaching them the testicular self-exam. And we also need to discuss things like sperm banking, because we are removing one of their testicles. So this is a 15 to 34-year-old male. I have lots of young males in the room right now. Like, most of you don't even have babies or probably aren't even thinking about babies right now, but you may be one day. And so it might be weird to talk to a 15-year-old about having a baby down the road, but it's really important that we don't that we broach the subject, because there's a high chance that they could not have a baby if we don't, sperm bank for them. And also to talk about their, in general, their maleness. I know that sounds silly, but I've talked to females who have had, breast cancer, that have had their breasts removed, that say they don't feel like a woman anymore. It's the same thing with a man. They feel that once their testicles removed, that they're going to look funny, they're different. So talking a lot about that is really important. And we need to teach young males their testicular self-exam. Every little lump or bump needs to be reported right away, because again, because it metastasized so quickly, we want to get early intervention. So we tell them that they should do it once a month, just like a breast exam. The best time to do it is after a warm bath or shower, because everything's hanging low, right? More out there. We should never do it like after a cold shower or jumping in the pool, anything like that. We tell them to take their testicles in both hands. Thumbs should be on the top, fingers underneath, and they should roll the testicles between their thumbs and fingers. They say that it feels like a hard-boiled egg. I don't know if that's quite how I would describe it, but again, if you all are going to go home and transilluminate yourselves, then you can take your, and let me know. And like I said, there should be, you might feel, blanking. You shouldn't feel any bumps or lumps. If you do any little thing that's different, you really need to encourage them. Tell them it's not silly. Let's get this, checked out, because you'd rather be safe than sorry. And I think these are just reviews, so you guys can do that on your own. I think that's it. Do you guys have any questions about that?